So this topic represents a gap in the established training for that progression, I believe. So there are a number of things, blood gases, blood chemistries, I think thrombolytics. There are a number of these topics that are just not thoroughly addressed in normal, shall I say, or standard paramedic education. And so the question is, how are we going to educate providers about these gaps? So I said, well, I can talk about these over the course of, I don't know how long we have. Is it years or a year?
2014, 2015.
Okay, so just probably have it done in a year, I suppose. So anyways, today we're going to talk about central lines. And we actually did talk about this 5 years ago in some respects, how to access them. But this talks a little bit more about some of that stuff. So PICC lines, these are very common. And I'm going to try to kind of whip through this. It'll be an hour's worth of education, but we'll do it in 20 minutes, 30 minutes. Peripherally inserted central catheters. They go in, usually the arm, and they go up into, usually just shy of the right atrium or the superior vena cava. They go up somewhere around in here. They're typically relatively small. I have never seen a 16 gauge PICC line. They're usually on the order of 20. They have what's called a Groshung valve. So I don't know if you've ever heard that word before. There are Groshung catheters. It's basically just a slit in the end of the tube. There's not a hole there. If you put a hole there, then there's just far greater chance of developing a clot within that hole. So this is just a slit that if you, oh yeah, thanks. If you put pressure on, it opens to allow flow out. If you can suck in, and it works just the opposite. Sorry for those of you watching the DVD. They are commonly used for long-term IV access. The most common is TPN, and then long-term antibiotics. So if somebody has osteomyelitis, a bone infection, we give antibiotics for weeks. That's a common thing. Some other chemotherapy can be, but chemotherapy we tend not to like to give peripherally so much. Even though this is put in centrally, chemotherapy is more likely they're going to get something called a portacath that we'll talk about in a minute. It's used exactly like a standard peripheral IV. You should pull back on it in case there's a clot in it with about 10 cc's, and then you can use it and then you flush with saline when you're done. Most are not heparinized. That's what they look like. Start in here, they go up usually about to there, sometimes deeper, sometimes not as deep. That's an example of the site. You want to use good aseptic technique when you're using these because they're in there long term. You definitely want to reduce the chance of infection. So you clean the cap either 3 times with betadine or 3 times with alcohol. If you're using betadine, betadine does nothing when it's wet. You typically would allow betadine to dry. Take your time with this and allow betadine to dry. When I'm using it, if I'm in a hurry, oftentimes I will take a gauze sponge and just blot it and give it some time to dry. Betadine doesn't kill anything when it's wet. Remember the days when they used to irrigate wounds with betadine solution? Pointless. All it is tissue toxic. We don't do that anymore because betadine doesn't do anything until it dries. Again, flush with 10 mils when you're done and use the clamps. It's just like using an IV. A portacath is a subcutaneous surgically placed central line. They're usually located in the upper chest. The tip of the catheter goes into the central vasculature, usually the superior vena cava. Again, used for long-term access. Usually cancer or other chronic conditions that need repeated blood draws. You can draw blood or labs from these, or medication administration. That's what the port looks like. That's what it looks like when you're just accessing it with a needle. They have specific right angle devices. There are a number of them on the market. And what needle to use is based on the overlying tissue thickness. So you basically just palpate it. If they're skinny like me, they don't need much. If they're big, you may need a longer needle. Prep it ideally with ChloraPrep, washing it for 30 seconds and then waiting. I looked at one of the manufacturer's videos. I didn't put it on here. But when they did the ChloraPrep, they went like this. That's not how you do it. You want to clean from in out. You don't want to bring contaminants into the central part. So anyways, so you just palpate this thing with your finger, kind of stabilize it, and there you can see this lousy picture of the right angle needle. You just put it in until it stops. If you have problems using it, you can back it off like a 1/16 of an inch or a couple millimeters.
How big are these? I mean, we have a little girl down in Belle Plaine that's got one of these, and they say use it, but until I saw that picture, I didn't want to stab a needle into it because I don't know what I'm poking.
Yeah.
I mean, how big?
Oh.
How deep? You know what I mean? For length of needle and that kind of stuff?
Well, I mean, the length of needle for hers, they probably even know, about a 1/2 inch. There are these needles on the rigs, right? Oh, we used to have them on.
I thought these were supposed to be access only under sterile conditions.
They are, and we're talking about if you need to use one in an emergency, you can. No, you're absolutely right.
I mean,
But-
like cardiac arrest or something.
Yeah. The likelihood is very small. But I remember, because I was carrying one, we talked about this a long time ago, I thought we had these access things on the rigs, but this is all last resort, emergency, can't get anywhere, how to access one. Don't do it routinely. I should have prefaced this, that's absolutely right. And I wouldn't quite say sterile, it's prepped sterile, it's clean, but it's not like sterile where we have gowns and gloves on and that kind of thing. So, no, I'm glad you mentioned that. This is not routine stuff.
So we can't use a regular needle?
If you absolutely had to give a drug, you could. If I can't.
Two different things. Down there they say, go ahead and use it. I mean, Sweeney even told us, use it if you have.
Yeah. No, I would not. I would not routine, unless somebody's dying and needs to get some medication IV. I would give IM pain medicines. If they're anaphylactic, they get epi and all that stuff and by other means. If they're profoundly hypotensive, then yeah, you could. And if they have the device, then you can. But again, this is for last resort kind of stuff.
Is it a lot better than an IO for that type of stuff?
No. Use an IO, when I get down here in my slides, use IO first. That would be my preference. I don't want to mess with any of these things, especially these. Central lines are usually hanging out of the chest. They're basically tunneled. The reason they tunnel them is because that length of subcutaneous tissue and space provides an infection barrier. That's why they do them that way. They can have anywhere from 1 to 4 ports. Dialysis patients usually have 2 ports. They have a blue one and a red one. Let me see if yeah, there's a blue one and a red one. The red one is not connected to an artery. The red one goes to the dialysis machine because it's then arterial, kind of, and the blue one comes back, is returned. It is not connected to an artery. They're both in the same central line. They can be used for central venous pressure monitoring, which is very helpful. They can be used for pacemaker placement. So we put these in emergently. The most common reason to do it is for sepsis, and we do that to get a CVP, basically, to guide us in our fluid resuscitation is why we do these in the ER, or pacemaker placements. Those would be the two most common reasons in the ER we would put one in. This is a highly edited video that shows kind of step by step how these are put in. So that's what this subcutaneous needle introducer looks like. So that's where the catheter will come out. And then it's going to make a turn right under the clavicle using ultrasound guidance, the subclavian vein, which is right there. So you saw on ultrasound the needle was in, and now they're using fluoro to watch where the guide wire goes. That's an introducer or a little dilator. It dilates the tissue so that the catheter, which is bigger, can go in. He's just putting in a bigger wire now because this is a bigger catheter and that other wire was too flimsy. All this is called the Seldinger technique. We use this for a lot of placement of tubes, of catheters, IV catheters, central lines, ART lines. Another dilator, because this is a big honking catheter, so that big gray thing is another dilator. It makes the hole bigger, kind of a stepwise process. It's taking it out over the wire, leaving the wire in. You never let go of the wire. Now that's the big honking catheter that goes in. And there they watch it go in. It's more complicated and more difficult than that. Even when we're doing central lines, it's hard because you're holding a needle and then you put this wire in through the needle. And if the wire's not going good, you can't pull the wire back out because the needle can cut the wire, which is a disaster. You get a wire embolus, no good. So, I mean, that made it look a little bit easier than it is, and obviously takes a lot longer. They can be done at the bedside. Typically, they're put in the OR. Significant risks. Serious infection, you can get catheter tip infections, you can get little vegetations that grow on these tips that cause infection. You can get clots, you can get stricture because it's a foreign matter or foreign material within the superior vena cava. You can get strictures, and that can lead to something called superior vena cava syndrome, where you get a lack of return from blood flow kind of from the neck up. And obviously we use very strict aseptic technique. This is where the whole patient is draped. We're wearing masks, gowns, all that kind of stuff. Dialysis catheters, there are lots of different catheters. That one I showed you here is one example. Usually they have two ports, and again, a blue port and a red port. If you need to, you can use the blue port if somebody is dying and you need to give IV something. That's why we're talking about this. It would be very rare now that there are IOs. And I'm surprised they're putting emphasis on this topic now that we use IOs, but it is what it is. Dialysis patients also typically this is the primary means of doing dialysis. This is the preferred method, and that is they connect a vein and an artery, and then what happens is these vessels basically dilate because it's a shunt and there's so much blood flow through it, and then they cannulate typically up here. They don't cannulate the artery in a vein. They're just usually cannulating the vein. They call it a venous needle and an arterial needle just because of the physiology, going to the machine and coming back from the machine. Some patients get Gore-Tex grafts, and then they poke them in the graft, basically. These eventually get clotted. And you've probably seen people that have these big grafts there that they don't use anymore, because oftentimes they just get clotted off. And there's two schools of thought how to access these. Sometimes they use the same point all the time. They call it buttonholing or something, versus poking in different spots every time. So the indications for use of a central line. In your protocols, we discuss PICC lines. It should be directed by med control. Emergent, life-threatening conditions. Cardiac arrest. I can't imagine one now with IO. And that's why this is different now. I just can't, but I suppose, bilateral femur fractures and arm fractures, I suppose, and they had one? Yeah, right. Yeah, right, yeah. I mean, I can't imagine a situation where you'd need to access one of these. But who knows, maybe it'll happen. If you do, you want to pull back with 10 cc's. Pull back with 10 cc's, you get the blood. Maybe there might be clots in these lines. You don't want to push clots in. They're tiny, but they could, if they have a AV connection somewhere, they could cause a stroke. A tiny clot going to the lungs is clinically insignificant. But anyways, you pull back to get the clots, and if they are heparinized, to get the heparin out. And then when you're done, you want to flush it with saline. Potential complications. Sometimes they can get pinched between the first rib and the clavicle. If that's the case, you can have patients lean forward, or they can shrug their shoulders up or back if it's not working. Thrombosis is always a complication, and that's why we want to pull back first. Use a clamp if they're leaking. Just clamp the things if they happen to get torn or they're leaking. Air embolism is another potential complication for these when they're left open. It's why when we put these in, we put patients in Trendelenburg so that things are going to come out. If anything's going to come out, it's going to come out, not suck in. If an air embolism, I'll talk about that in a little bit actually. I'll talk about how to treat that. So the other thing that we use these for is monitoring, and they're actually very helpful. The sepsis guidelines as of whenever it was, 5 years ago, longer I think. The can't remember the name of the campaign. Anyways, the guidelines for sepsis now are to keep patients in the ER and be pretty aggressive at monitoring and treating these patients. Part of those guidelines are placing a central line and an art line to get an estimation of central venous pressure. Okay? So what is central venous pressure? It is the pressure in the right atrium. It approximates the right atrial pressure when you have a central line in. So it can be in the SVC or the IVC, and it approximates the pressure within the right atrium. This is what a right atrial pressure tracing looks like, and you'll see that it's biphasic, meaning there are two peaks of pressure. This is the biggest reason we do central lines in the ER is to estimate total blood volume and to guide our fluid resuscitation. Here's another picture of why this is biphasic. So the first one is the right atrium squeezes blood into the ventricle. Okay? Then it relaxes, and the ventricle starts to squeeze. And when it starts squeezing, it actually pulls on the right atrium and generates negative pressure. Then, as right ventricular contraction continues, it then puts pressure on this and starts another positive peak. So this is kind of, and that's this V wave here, ventricle wave. That's from ventricular systole. Okay? So it's actually kind of triphasic. And then it beats again. So, but you get this little peak here, this C, and that's from that little shoulder is the start of the ventricle beating and then pulling in or kind of sucking on the right atrium. So there are a lot of things that can increase central venous pressure. The simplest to think about is if someone is volume overloaded, they will have a high CVP. But there are many, many other things. Tension pneumothorax, heart failure, pleural effusion, obviously. Poor cardiac contractility can increase it. Tamponade, that's I was thinking pericardial effusion when I read that. And mechanical ventilation. Mechanical ventilation basically supplies positive intrathoracic pressure. So it's kind of the same reason that these two, forced exhalation and pneumothorax, increase it. What can decrease it? Hypovolemia. Deep inhalation generates a negative intrathoracic pressure, which decreases it. Obviously, that's transient. And then distributive shock. So what are some examples of distributive shock? Well, I just talked about one. Sepsis, spinal cord injury, yeah, neurogenic. One other one. Anaphylaxis, good, yeah. Those are the three. The other thing the reason we really like to know CVP is that this is how it can kind of help us, and this is the physiology behind what happens with it. This is a very important, probably the most important relationship in cardiac physiology. It's called the Frank-Starling relationship. And it's basically that as you increase preload, you increase cardiac output to a certain extent. But this whole plot can kind of shift. So if you increase right atrial pressure, you increase volume, you give the heart more blood to fill with, it shifts this over to the right, and this point goes up here. Okay? If you increase contractility, so you give dobutamine, then you're moving this whole curve kind of up and that way. So you basically get more cardiac output per less preload. Not that you'll necessarily remember that. So how do you use it? In the old days, we used to use a manometer, so a mercury-filled tube. Now we use transducers. And this is actually key, that if you are watching central venous pressure, the transducer has to be placed at the fourth intercostal space, or it has to be placed at this level. You can tape it right there, but it has to be placed at that level in the mid-axillary line, and that is to establish the zero. There shouldn't be any air bubbles in it. Little ones aren't a big deal. It just dampens the signal then. And typically we measure this or refer to this in terms of centimeters of water pressure, not millimeters of mercury. Bleeding, infection, occlusion, displaced catheters, these are all the possible complications. If you leave one of those stopcocks open or the tube is left open, you can have air embolus. And this is what we're always nervous about when we're putting these in. They take a deep breath in and the catheter's open and they suck a bunch of air in. We treat it with 100% oxygen. You put them in Trendelenburg on their left side, so hopefully keep the air bubble at the apex of the heart and give it time to dissolve. If they go into cardiac arrest, theoretically doing CPR can break it up into smaller bubbles, which are less harmful, and then you can reestablish some fluid dynamics, so to speak, but they can basically get airlocked. But the first thing, if we're putting in a line, and this is ER board's question, and somebody suddenly becomes pulseless or they're unresponsive or you lose their pressure, you worry about an air embolism and we put them Trendelenburg on their left. Not that you're ever hopefully going to run into this problem, but anyways. There's your bridge education on central lines. All right. I am going to kind of continue on this bridge education that we need to provide. Huh? You'll think of some questions? This is interesting.
Keep in mind that the two at the top are the most important things in the world for paramedics to know. Just ask them that.
Yeah.
Second one said something.
What's this? Cauda equina? Yeah, equina. Cauda equina syndrome. You'll learn all about it, Brent. This is just an interesting thing to learn about, quite frankly. I think trainers and coaches need to understand it, but just watch this video. Yeah, he's in VFib. Isn't that fascinating? He wasn't going like, oh! You know, it's not like he cracked a rib or broke his sternum. What should someone be doing by now? Yeah, pushing on the chest and getting a defibrillator. I'm going to, because it's actually, it's actually kind of interesting to see it. Oh, totally. No, I
mean, his arm was coming. I wasn't sure if that was.
So right there. Oh. There's the hit. That's where his heart stopped. I mean, and it's a kind of a fascinating thing to watch. Look at it. Up. He's still ambulatory. Isn't that amazing? Boom. So, and that's the reality of this, depending on how exerted you were prior to it. So, a football player that gets hit, which is an uncommon mechanism, but they'd be more O2 depleted and more exerted and would drop quicker. Whereas, a catcher on a baseball team may maintain some consciousness for a few seconds as well. Excuse me. So what is it? It's a sudden cardiac arrhythmia from a blunt chest wall blow. There is a national registry maintained actually by Minneapolis Heart Institute, and as of I didn't have access to the list, but the most recent citation of that list I could see documented 210 cases. And I think they started in 1996, if I remember. There's the age range, which is really kind of scary. The mean age is 15 years old. Very few are less than 10, so a quarter of them less than 10, and very few greater than 25. Not quite sure why that is, actually. Most of the cases happen, it's about half during sporting events and half during just kind of daily recreational activities, kids playing. The overall survival is 15%, which is it's not terrible for cardiac arrest, but if you think about it, this is witness shockable VFib arrest. That's the most survivable kind. The survival should be 45 to 50%, quite honestly. But we've come a long way, and that is average data from this registry, which is, even pre-2005 AHA changes. So if you look at the sports, baseball, softball, hockey, there are some football, lacrosse, and this is again, lacrosse is kind of a growing sport in many regions, especially around here. This is actually a sport that has taken a huge interest in trying to prevent this and educate people about it. And again, this is kind of differentiating recreational sports from actual competitive sports. The mechanism, it's very hard to do. And you can see on that EKG tracing there, the very narrow window of time that the trauma has to occur. And so it's right on the upstroke of the T wave. That's the vulnerable period of time, kind of almost like that R on T phenomenon that you worry about a PVC coming at that time. It's kind of similar to that. It has to be directly over the left ventricle. The velocity of it, velocity is a lousy way to quantitate this. It should more be the momentum of it. It's the mass of whatever it is times the velocity. I mean, you throw a wiffle ball at 40 miles an hour, hit someone in the chest, it's going to, slap their skin. So but they use it in terms of baseball velocities. So that would be a different velocity necessarily for a softball. I'll show you in a minute. It also depends on how hard the ball is. But here you can see there's some critical velocity, and it's 40 miles an hour. And that is not uncommon in 10-year-old Little League baseball. That's when they start pitching about 40 miles an hour, is around 10. So that's kind of where this age thing kind of comes into play. They have studied chest protection, and it doesn't work. There's one device that may work, and it actually is made of almost like a beanbag chair, little foam balls like that. And that is the only device that in these pretty big studies that showed a trend towards decreasing the incidence of this. So right over the left ventricle, and if you really looked at that, you probably couldn't see that video, but that guy's fist was right there. So there's really a pretty, and I just drew this in an anatomy picture. I mean, that's not from some published study or something. It's a pretty small window that it needs to happen at. And if you look at, this is a study that was done Tufts University, I believe, where they looked at, specific, they used an animal model and looked at very specific parts of the heart, and basically the center of the left ventricle coming down to the base of the left ventricle is the high place of vulnerability. So, getting hit in the side, obviously in the back, it's almost zero. But it's this area, the center of the base and the apex, that is that vulnerable area. Again, here it kind of just shows they tried, softer baseballs, and they definitely make a difference. And then obviously the speed comes into play there. And there's also a bell-shaped curve in that if you exert more pressure on the left ventricle, the chance of this happening actually goes down. They don't know why that is, but if you hit it too hard, it goes down, and that fits with the age distribution. So when you're in college, you're throwing too fast and you impart that much pressure on the left ventricle and it doesn't induce the arrhythmia. So it's a very interesting phenomenon that happens in young people, which is really kind of scary. This diagram, which is, there was an article published in the New England Journal of Medicine just a few years ago, actually, that was from this cardiologist at Abbott. That's a great summary of it. And this chart kind of just shows everything about it. And it has to do with talks about the more thin, more compliant chest wall in children that allow it to happen. And there you can kind of see the objects that are involved. So this is one of the keys, and I think this is something coaches need to know, athletes need to know, obviously, to recognize it. Trainers need to know. It's not a big, huge, major blow to the chest. It's seemingly innocuous or inconsequential. I mean, they get hit in the chest and they turn around and keep going, and then they drop. And Beyond that, I don't know what more to teach you about this because you know how to take care of VFib cardiac arrest, and I'm not going to go through that, obviously. That's what they need. They need immediate CPR, they need defibrillation, and then standard ACLS. But I think it's recognizing this, and if you're standing by at a sporting event, you know, and you see an athlete walking and dropping, it should be the very first thing you think about. The other thing that happens in athletes is sudden cardiac arrest from underlying undiagnosed cardiac abnormalities, and it's usually something called subaortic stenosis or hypertrophy. They are at risk for arrhythmias. So bottom line is, if you see an athlete drop, it should be very high on your list of possibilities. Prevention, obviously, awareness, chest shields. Again, there's just no scientific evidence to suggest that, other than one called the Brine Pro. They have one, there are organizations out there that are trying to prevent this, and there's one that looks more like a nut cup, basically, for lack of a better term, right over that portion of the heart that's supposed to deflect it. But again, just unfortunately, none of these have been shown to prevent this, at least in animal studies. Theoretically, you'd think they would. There's some references. I think this will be posted if you want to look these up. But it's that New England Journal. That's the most recent one. That's actually a good article. All right, I'm going to keep moving on. I don't know why this is in there, to be honest. Well, I do. Actually, I mean, there's something about these topics and why I kind of picked them together for the most part. And the point I want you to take home, or that really is worth talking about, is the notion that seemingly innocuous things or routine everyday things, and when we get to injection injuries, that is a great example of that, are really more emergent than they appear. Back pain with a cauda equina syndrome is an emergency. I mean, it's bad. So it's worth understanding what that is. It's not something you're necessarily going to diagnose. But, you know, if you're seeing someone and they have these symptoms and they're refusing to go in, they just need to understand it could be this, and this is an emergency that can leave you kind of disabled if it's not treated. So, and it results basically from the compression of the cauda equina. And the cauda equina, the spinal cord ends at about L1, and then it's basically just nerve roots that go down, or peripheral nerves that go down the rest of this spinal canal and go out through each vertebral process. And it's like cauda equina means like horsetail, is what that stands for. That's what the syndrome describes, is compression of these nerve roots somewhere along their way below the spinal cord. So nerves from L1 down through S5 come out at various levels from this cauda equina, as opposed to ones that are higher up come right out from the spinal cord and go out through the vertebral processes. So anything that compresses on this bundle of peripheral nerves causes cauda equinal syndrome. One of the most common things is a herniated disc. Now, when most people herniate a disc, it tends to herniate out the sides for whatever reason. Discs tend to be a little weaker there, and they push on nerve roots, and they get pain that goes down their leg all the way down to their foot sometimes. They may get numbness or tingling and loss of reflexes that are responsible from that nerve or innervated by that nerve. This is a central disc protrusion, so it's pushing out right into the spinal canal and pushing on those nerve fibers. That is what cauda equina syndrome is. Other things that can do it are just a narrowing of the spinal canal, chronic inflammatory processes like neuropathy or tuberculosis. Other things can irritate the nerve and give you the same syndrome when it's not actually compression. This is the biggest one, and if you look at I guarantee every discharge instructions we tend to write for people when we send them home from the ER, we say if you lose control of your bowel or bladder, you need to come back. Or you have a fever. I mean, those are the two big things with back pain we worry about. Why fever? Epidural abscess is kind of the main one. That's a horrible condition to have. But cauda equina syndrome is the other. I mean, everyone that leaves the ER should be educated that if you are incontinent of stool or urine, you need to come back, because this is an emergency. So in some respects, it's not so bad that you guys understand these things. So that's one of the biggest things. And usually it's not that they lose control to keep their urine in. They lose their sense of needing to void, and they actually overflow. So they have an overflow incontinence typically. or they lose rectal tone and are incontinent of stool. They will usually have something described as a saddle anesthesia, so they have decreased sensation in the distribution of where you would sit on a saddle, basically, and that's just because that's innervated by those groups of nerves. They may have sciatic leg pain, so that same radiating pain down the leg. They could also have muscle weakness in those specific groups as well, and then decreased reflexes. When I trained, so that was now 15 years ago, this was the only reason we ever ordered an MRI in the ER, is for this exact thing. Things have changed. The next thing that progressed actually was epidural abscesses. That's kind of the next use of emergency MRI. Obviously, it has progressed to we get it for headaches, we get it for seizures, we get it for all kinds of things now because it's so readily available. But this historically was the only emergent indication to get an MRI. And quite honestly, if we're getting MRIs for back pain in the ER, this still should be the way or the reason we get it. And sometimes claims are denied because they didn't fit criteria for caudate equina syndrome when we got a lumbar spine MRI in the ER. We do it more and more just to facilitate more expedient care, and the rationale is that we can get people back to work sooner. If we know they have a herniated disc, they can get a steroid injection in it, blah, blah, blah. But anyways, historically, that's the only reason we got them. The treatment of it is urgent, not necessarily emergent. It depends on what's causing it and how significant the symptoms are. So urgent meaning within 48 hours. You know, oftentimes it's because this is published in the orthopedic literature, and those orthopedic surgeons, they don't want to necessarily come in right now in the middle of the night if they don't have to. So when they publish these things, they describe things as urgent and emergent, and this one sometimes can wait. The reality is that not many orthopedic surgeons will say, let's see, it's Saturday evening now, I'll wait till Monday and do it Monday morning. No, it needs to be done sooner than that. But again, it depends on the source. If it's an abscess or an expanding hematoma, it needs to be done right away. They need to come in. So it's a big deal. Any questions on caudate equina syndrome? Chest tube management. Doug, can you do me a favor? I think there is an open Pleurovac in the ER. I meant to get that this morning and was running behind. Could you ask Kathy or one of the, if at some point you could run one down? This is something you probably do encounter on a semi-frequent basis, is taking a transfer down that had a chest tube placed. So this is definitely something I think that's important to understand and how to manage it. So obviously, you know, we put these in to evacuate either a hemothorax or a pneumothorax. And that's what's going to determine what size tube we use. Almost always, even if a pneumothorax is related to significant trauma, we use the bigger tube. If it's a spontaneous pneumothorax, we would probably use a smaller tube because there's less likely to be any blood. So this really is only for spontaneous pneumos, our small tubes. And then even sometimes we use small anterior pigtails, and those are managed a little bit differently. So I'm primarily talking about trauma, pneumothorax, and chest tube placement. This is a little bit of a diagram about it. They're placed typically in the fourth intercostal space, which tends to be at about the level of the nipple, which means we make the incision one level below that. We kind of cut out, we anesthetize it, we cut over the rib. It's often tolerated with just local anesthesia. I did one a couple weeks ago with no sedation because the patient's blood pressure was low, and they tolerate it quite well. So that's more how much time do you have, what's their blood pressure, but if you numb them up enough, you can do this remarkably pain-free. Again, we cut one level below, and that is to make a bit of a Z-track so that there's less likely that it's going to leak. What we do, and I'm going to show you a video of this, we make an incision, then we use a big kind of hemostat to blunt dissect up over the top of the rib. And then what we do is we just poke it through, and if we're doing the big trauma ones, we spread that hemostat and then we pull it out. And it makes a lot of noise, and you usually hear a rush of air, or in the case of the one I did the other day, got a huge rush of blood, and patients start to get better just with that, basically. Then you feel with your finger. You usually want to feel, make sure there's no adhesions around there, and then you advance this tube. Almost always we want them to go down or posteriorly, so down when a patient's lying flat, and up. Then we suture it in place. Typically, that's just one stitch on the skin and then a bunch of half hitches around the tube. Then we cover it with an occlusive dressing with some bacterial or some bacitracin and some gauze. And then you want to attach it to this device, which hopefully we'll get one here. Oh, that was quick. And then we always verify these with a chest x-ray. So, and I'll kind of just describe this thing here in a little bit. There are many different models. And I guessed wrong at the model we had, sorry. So this is a quick video that just kind of summarizes this placement. So you have to fill these things with water. Some have a water seal. Others have a little bubble indicator. It's an air leak indicator. Obviously prepping it, keeping sterile. That's anesthetizing. There's making an incision in the area that he anesthetized. You can see it's about one level below. This usually represents the fourth intercostal space, so you cut right on top of the rib below that. More anesthetic agent, deeper in on the pleura, basically, because it hurts when you poke through the pleura. Then they basically just advance the tube up, suture it in place, and then a tight gauze dressing, and those are the guys that make this video that you have to pay for the full version. It's too cheap to pay for it. This is why we get x-rays. This is a great picture. So these things have a hole on the end, sometimes a hole down here, and they have a hole there. And that's the reason these lines are on there, are to be able to see where the hole is. Do you think that one's going to work very good? Yes, it will suck some stuff out here, but if it's not secure or tight right there, it's going to suck air through that hole, which is outside the chest, and it's going to inadequately evacuate the problem. So this is why we get them. Here you can see some rib fractures and stuff on there, but that's important to look at that hole. Many of the chest tubes, it depends on what model you get, only have a line that goes to the hole, and then there isn't a line, so you can kind of see where that last hole is. So these devices are compact and better form of the old way you used to do it, but this shows you much nicer exactly what these devices do. They work the same way as these bottles, and this is how we had similar devices even when I was in residency. The problem with these things is you can't tip these. If these things tip over, they completely mess up. These are at least a little more tolerant of that. They're supposed to stay upright, but they're less prone to problems. So the patient is over here, and this goes to suction. So it's pulling blood out here, and the blood just drips down, or air, but still maintaining suction. This is an air leak indicator. So this is basic, or a water seal. So air can't go back that way unless you generate more than typically about 10 centimeters of water pressure for a water seal. And so that's what this height of water determines how hard the chest would need to generate negative pressure to pull air back into it. So that's what this height of this water determines. And then you watch these bubbles here, and you can tell if you're still pulling air from the mouth, through the trachea, down through the lung, and out the chest tube. And that tells you that whatever was broken to cause this problem still hasn't healed. If it's a pneumothorax, you should have an air leak when you put a chest tube in. Something led to the pneumothorax unless it's healed and done, but typically you'll have a little bit of an air leak until that hole heals. This determines how much suction there is. So if your wall suction is on full blast, it doesn't matter because it's still only generating enough vacuum to pull air down through this tube. So the height of this water, which would typically be about 20 centimeters of water, so here you have 10, here you have 20, this determines how much vacuum you're pulling, not the regulator on the wall. The regulator on the wall is too inconsistent. There's no two ways about it. You have to generate enough vacuum to pull down however high this water level is. And that's what that does. So you can see if this thing tips, it's a problem. It's a big problem. If this thing tips, you can be pulling straight wall suction. These devices, on the other hand, have a dry seal, so it doesn't rely on this bottle to generate the water, or to generate the seal. And they also have a regulator, a little dial on them that you can adjust the suction. They still have water in them. And there's no other good way to detect an air leak than to watch bubbles through an indicator. So you have to put some water in the air leak indicator, which is down here. But these have indicators that show that they're hooked up to vacuum, and they have a way to dial in the amount of suction, 10, 20, 30, 40. Usually we start at about 20, typically. And then they also allow for the collection of the fluid, which I think 2,500 is max on this one. And it starts so smaller amounts can be measured more accurately, and then as you start to get more and more quantities, obviously you don't care how accurate you are, but you can pretty accurately measure how much drainage there is. Anything I missed on here? No. So, just some general guidelines for chest tubes. In general, the chest tube should never be clamped. There isn't a good reason to ever clamp a chest tube. The only time we clamp chest tubes are when we're taking them off suction and we want to see if they're ready to have their chest tube taken out. But if you're having a problem with a chest tube, the last thing you want to do is just clamp it, because then whatever that chest tube is evacuating can potentially reaccumulate. So better would be if you're really having problems, you'd want to take them off, put a Heimlich valve on, or use a glove on the end of the chest tube if you're really having problems. But so in general, they shouldn't be clamped. Typically, they're left on for 24 hours after an air leak stops. Again, you want to keep them upright, and you don't want this thing above the level of the patient. Typically, they're below. You don't want the tubing draping down, lower them. Things to monitor, vital signs in general, no doubt about it, but obviously respiratory rate, respiratory effort, and O2 sats are good indicators. End-tidal CO2 is another good indicator of worsening pneumothorax, airway pressures, those kinds of things if they're intubated. Lung sounds, obviously too hard to do in the back of a rig. You can watch for progressing subcutaneous emphysema. If someone has subcutaneous emphysema, they have an air leak by definition. Trauma patients with sub-Q emphysema, we consider that to be a pneumothorax, even if we don't see it. Oftentimes they get chest tubes. Obviously, we want to monitor fluid output. If this thing's just gushing out fluid, that's going to be a problem. Ideally, when we get a lot of return from a chest tube, we auto-transfuse that. It's perfectly good blood for them to put back in. It's about the only cavity in the body. Abdominal blood, you can't do that because it could be contaminated with what? Poop. Yeah, you don't know if there's a perforation, so you could have contamination. But blood that accumulates in the chest cavity is considered clean and can be transfused back into patients. So there is, if we're suspecting a huge hemothorax, and we usually see it on a chest x-ray, we put another device on here, which is just a collection bag for the blood that allows us to either put it right back in if we need to, or wash those cells with normal saline and transfuse them. Then the other thing, obviously, we monitor for air leak and air bubbles. And if you're suddenly just getting this air leak indicator, this little bubbler is just constantly bubbling, that can be an indication that it's not necessarily a problem with a patient, but you can have a leak in the seal of these tubings. You can see here we use these nylon tie wraps to secure them. So, the first thing you would check if you have a huge air leak is there some loss of seal on the tubing? Did this thing tip over and get cracked or something like that would be kind of some of the first things. Actually, I'll move on to troubleshooting. You should have air leak, and it should change with respiratory effort. But again, if it changes, then you think about a crack in this device or a leak in the tubing. You can clamp it to determine where your air leak is from. So if this long tube goes to the patient and I clamp it here and the air leak continues, well, then I know the problem is somewhere from here downstream towards suction. So we do use clamping to kind of sort out where a bad air leak is from. That's something else that you can do. Other things to think about, the tube could have come dislodged, and that last hole I showed you on the x-ray could now be out of the patient. If that's the case, the best thing to do would just be occlude that somehow, Vaseline gauze around it, or just more tape. Somehow try to occlude that air leak. Again, if this device is cracked or broken, then it would be a time I would get on the radio, talk to a doc, but what I would instruct you to do is take it off, and I would tell you to do the glove trick. You cut the finger off a glove, you put that over the chest tube, and the end off the glove. That's how I would fix that. So if the tube just comes out, 3-sided occlusive dressing, just like a penetrating chest injury. Again, I already talked about what happens if this is a bad air leak and the patient's getting worse. Again, clamping the tube is usually not indicated. All that's going to do is allow reaccumulation. If a tube seems to be clotted, you know, the drainage is stopped and somebody's getting worse, you can what's called milk it. This is pretty flexible silicone tubing that you can kind of milk and try to get a clot out. It usually doesn't happen for sometimes days after. It's not something that's going to happen necessarily immediately. Any questions on the chest tube stuff? Really, these devices are going to be kind of set up and going. You're going to see the little bubbles in the air leak indicator, and you're going to know what your output is. And I think it's very reasonable that when you're assuming care of a patient, you note where that is. You will see marker lines on these things. That's how we keep track of it with dates or times. I would just note where it is. If you want to write on it, put a marker on yourself, you know, EMS or something, or out of hospital, out of ER. That's perfectly appropriate because you should have some idea when you get to the receiving facility and what that output has been. Yep.
The only place on there that we're looking for that air leak or the air bubbles coming out is that lower right corner.
Yep, down here. Mm-hmm.
It should have water on it, there's lines that show you where the water should be.
Yep. There's a little indicator right here. There should be water up to this level, and you will see bubbling in that. There are other models that you can actually quantitate how much the air leak is by different bubble indicators. We don't have those.
And the models change really frequently.
They unfortunately do, because we used to have ones like the one I showed you in that picture.
The other thing to note is those things are really, because they have to be lower than the patient, we usually have them hanging on the rails, and loading and unloading the patient, they can get crushed.
Yeah. And the tubing can be stepped on, and keep that tubing up at the level of the patient as much as you possibly can. You know, if the tube comes off, put it back on. I mean, it's that simple. The only sterile point is where this goes onto the chest tube right here. Everything else beyond where you saw that tape on the patient is not sterile, for the most part. The connection isn't. Just put it back on. And you can do it without the tie wrap. It's not necessary. That's obviously supposed to minimize that potential. Anything else about chest tubes? All right. This is an interesting injury, too, in that these can look like absolutely nothing. Many people don't even come to an ER when this happens to them because they tend to be kind of stoic mechanics, you know, or something. No, I'm fine. It's just a little mark on my hand. But they actually are relatively common, 1 in 600 hand injuries. When you think about how many fractures make up all hand injuries, this is still a significant portion of them. It does not take much to disrupt the skin. But remember that PSI means how much square inches it is. And so when it's a pinpoint nozzle, it doesn't take a ton of pressure because the surface area that it's hitting is low. So, because most car pressure washers can be a couple thousand psi, and if your hand is this far away from a pressure washer, it doesn't hurt you. So, it is actually still a pretty high-powered device that causes these. Typically, paint guns, grease guns, that kind of thing. Diesel fuel injectors. So the way a diesel engine works is there's an injector. It's a little nozzle that diesel fuel is essentially atomized with. And it takes a lot of pressure to go through one of these diesel injectors and make that mist of fuel that's combustible. And mechanics working on these, if they get their finger in front of that, if they're testing these injectors, can get diesel fuel injected. They almost always occur on the hand, just because people working and cleaning things, like a painter will clean his spray gun with his index finger. They're usually non-dominant, but they can also occur, if someone else points one of these devices at someone, they can occur anywhere. Most are from grease and diesel fuel. Thinner other paint like solvents or paint thinners tend to be much worse because those thin, less viscous chemicals can spread farther up into tendon sheaths. Water and air are obviously less severe. Water just depends on how dirty the water is. Davo.
I've got a couple of hydraulic ones where they're checking the line for leaks, they run their hand over it,
Yeah, and
they find one.
yeah. I don't know how well this projects, but this is what they can look like. I mean, it's a tiny puncture wound. Looks like maybe a sliver. And that is what this is not. If you look closely at these pictures, this is not. Obviously, this person sought medical attention. They got the picture of this. Did not turn into that. This is a little bit, but there's no question that can progress to that 48 hours later if untreated. I mean, it's horrible. So they tend to be occupational. They tend to be non-dominant because these things are high pressure. They take strength to control. So they're holding this pressure thing with their dominant hand and doing something with their non-dominant. Except the leak thing, they might do that with their dominant hand. But the fingertip is very common. The initial thing is not very painful. They may have a little pain with the movement, but they can keep working. And hours later, you start to get necrosis, not only just from the pressure building in there, but the chemical itself is irritating the tissue. They'll present with fever. They have severe pain with passive range of motion. And this symptom is something you ought to know about for many, many, many different things. And that is that if you have an injury or an infection in your tendon sheath and you just move someone's finger like that, they will want to swing at you because it hurts that bad. That is a bad sign. The same thing can hold true if you move someone's foot and they have a problem with their calf. That can indicate something called compartment syndrome, which is severe pain. The other thing is necrotizing fasciitis, can present with this symptom. Severe pain or pain out of proportion to the apparent injury or problem is a bad symptom. Don't ignore it. And then obviously they can develop a compartment syndrome in a hand that looks like that. So what do we need to do? Well, from your perspective, the biggest thing you can provide to us is figure out what the substance is that was injected and how it got injected. So we have some idea of how this might progress and how urgently it needs to be done. If it's grease in the fingertip, it still needs to be fixed. It may not be as urgent as lacquer thinner that is clearly in a tendon sheath. So, and then obviously we clean these wounds, we start pain medicines, and we give them prophylactic antibiotics and tetanus, and they need to go to the OR. And here you can see how they plan for this. They do these incisions this way. If you just cut someone like this, then you have this big thing that kind of fillets open and there's more tension. This takes advantage of going 45 degrees to tension lines. And so when they open up, you can see these are open right there. They don't just fillet them open. There's much less tension on the wound when they close it. That's why they open them that way. So this is what high pressure oil does. And you can see that this damage was more limited to this part of the finger. That oil is thicker and it doesn't spread way up the hand. But that is essentially an untreated oil injection injury. This is what paint can do. This is someone that obviously they sought medical attention quite delayed. This fingertip is necrotic and dead. This one's looking like it's going to be. And here you can see what they do when they operate on these. They open them up, they wash it out, they get all that junk out, and then they leave these open because they can't get everything out. And the more you leave something open and allow to drain, the less likely it is to get bad. But obviously that person did not have a great outcome. Lost their index finger, which is bad, bad, bad. You don't want to lose your index finger, and most of their middle finger. This is some of the weird things plastic surgeons do so that oil injection injury, how they treat these sometimes. This finger is sewed into someone's chest wall. It's sewed into there to allow it to heal and granulate because there's good blood supply to this chest. So this person walks around with this for weeks. And then what they do is they cut it out like that around here, and they take that flap of skin and then they close it over the fingertip. And it's a good way of doing a full thickness skin graft, actually. The problem with doing a full thickness skin graft right here is you don't have big arteries to attach it to. There's just little arteries there, so they usually don't take. Whereas this allows all this stuff to heal under there. I mean, it'll be a pain in the butt to walk around like that, but they do get a good result, actually. It's kind of interesting, some of the things plastic surgeons do. Yeah?
That was what's called to a scene where a guy that had this with him was arrested, and he refused to comply with putting his hand behind his back.
Yeah.
And they tried to force it. There was some tearing and stuff, and we got called, and the first words out of the cop was, "What the hell is that?"
I can imagine. You don't see it very common, but they still do some flaps that way. There's a lot of other techniques to doing flaps in other parts of the bodies, but in terms of the hand, this is one that is still used. All right, any questions about that stuff? Just kind of interesting. All right. On to thrombolytics. So I'm going to just kind of talk about the background, some clotting physiology, more than you ever wanted to know about blood clotting. I don't expect you to remember a tenth of this, but there are some, maybe you've heard about some of this stuff that I think is worth clarifying. Helps me to teach it again because I forget a lot of it, and it's kind of interesting how our blood clotting works. You guys you administer medicines that do this stuff. You give aspirin, you give Brilinta, you take patients on heparin, you take patients on thrombolytics. So I think that this stuff is very important. I think it's important for you to know how we manage some of these conditions in terms of the therapeutic uses. So, and for the most part, this is all we use thrombolytics for, those things right there. So, thrombosis is the formation of clot in our body. It's an obvious necessity, and it is balanced by our own intrinsic thrombolysis. Our body balances that. Things activate the clotting cascade. When those things that stimulate clot formation go away, our body then starts to dissolve those clots. Normally, a vessel doesn't occlude unless it's already narrowed from something, and so that's the problem with having atherosclerosis, that your vessel is narrowed, and it also, if the plaque or that narrowing ruptured, it exposes the endothelial layer, which then starts this clotting cascade. So the whole clotting cascade kind of depends on the integrity of the vascular wall. That is a big thing in terms of starting a clot formation, and then platelet response and other inflammatory mediators. But basically, clots are started by platelets. That's the first thing that starts clot formation. So what happens is you have injury to a vessel, and a few things happen. Anytime you injure a vessel, it causes a spasm of the muscles in our artery. Remember, arteries have smooth muscle in them. That's how we kind of vasodilate and things. So it vasoconstricts. It exposes this collagen, this chemical that makes up the connective tissue of our vascular wall, and that stimulates platelets. Platelets start to aggregate, and then also with this damage of the tissue outside the vessel wall, you start to have this clotting cascade activated, and that's what things like heparin and Coumadin work on. All right, so it's kind of a multifaceted thing. The bottom line is you take thrombin, prothrombin turns into thrombin, which turns into fibrin, and then fibrin. It's really like a fiber. Those fibrin molecules kind of stick together and form a fibrous clot. So this platelet phase is very, very important because this is what we kind of attack this phase to prevent things like heart attacks and strokes. Okay? It doesn't involve pulmonary embolism because pulmonary embolism is a clot formed somewhere else, not necessarily due to vascular disease. It forms in the veins and it goes up to our lungs. MI and stroke are arterial problems that are related to atherosclerosis. Again, that atherosclerosis is vascular injury. So that's why we don't give aspirin to people to prevent PE. It just won't work. It's a whole different mechanism. Again, platelets start to basically, they aggregate. They contain receptors on them to attach to fibrin. So after you get injury to this vessel, the first thing that happens is platelets start to aggregate. They release a whole bunch of other chemicals that kind of continue on with this regulation. And you can see how complicated it is. It is pretty complicated. But the bottom line is they form a plug. And then you start to form fibrin clot on top of this platelet plug. There are a lot of things you'll see here. This ADP, adenosine diphosphate. You see this G glycoprotein 2B3A. That is, we used to give what was called integralin, I think. We can inhibit platelet aggregation by blocking these receptors. We can inhibit platelet aggregation by stimulating these receptors or blocking this thromboxane. All these chemicals are important as to how antiplatelet agents work, which I'll talk about in a minute. So then we have this coagulation phase. And there are two phases of the coagulation. One is the intrinsic phase, which is inside the blood vessel. The other is extrinsic phase. So just think of X as being outside the lumen. So the extrinsic phase is from tissue damage. So remember when I talk about the quiz, this is an important part to remember for the quiz. That extrinsic pathway is stimulated by tissue damage, not vascular damage. Okay? Lots of factors. Vitamin K is very important in this whole thing. It's activated sequentially. Here's another thing that distinguishes these two things. So this intrinsic pathway, which is more about deep vein thrombosis. Okay, that's from within the lumen of a vessel. You usually have to have some blood vessel injury. For DVTs, you don't. You have to have stasis. Blood just sitting there, pooling, it will clot. But when you have damage, it's activated by platelets. It's much slower, and we monitor this pathway by checking PTTs. This is the one outside. It involves tissue injury because it's activated by tissue factor. It's much faster, and we monitor it by protimes. So protimes on the order of 12, PTTs are on the order of 30. Those labs reflect how one is faster than the other. Here's how complicated it is. Obviously, I don't expect you to know anything about this other than gee whiz. This is how these chemicals first get activated. An activated one makes the conversion of another one to be activated, which makes the conversion of another one activated. It's highly complex. I had to know this in medical school to pass tests, and then for my boards, and then an ER once for the boards. Well, actually, we need to know this for our boards. We need to know what meds are affected by heparin and Coumadin, not even necessarily the order of this whole cascade. But Coumadin affects factor 2, 7, 9, and 10. It basically lowers the amount of these active chemicals in the blood, and then heparin affects these activated chemicals. So just more kind of gee whiz. Here it's separated into that extrinsic pathway, the intrinsic pathway, and then which ones are in common. The thrombin to fibrin is kind of that final stage that's important to both. So what about anticoagulants? What do they do? How do they work? We can give them IV, and that's heparin, and that's good at preventing venous thrombosis. Remember, that one was all on the intrinsic side, so it can help us prevent DVT, PE, that kind of stuff. Coumadin also affects both, so we use that to prevent DVT as well, and it's an oral medication. Aspirin is an antiplatelet, which decreases platelet aggregation. Thrombolytics actually break down that fibrin that has already been formed. So what do these medicines look like? Heparin can be low molecular weight heparin or unfractionated heparin. So when you take someone on a heparin drip, they're getting this, unfractionated heparin. You can give it sub-Q, but we almost always give this IV. You saw all the factors that it affects. We monitor how we're doing with heparin by checking PTTs, or now, actually even better, we measure how much of this anti-factor X activated there is, activated factor 10. That gives us a much better measure of exactly how much heparin we need or how much we're giving. The benefit of this drug is that we can give a medicine that completely reverses it very quickly. So if someone starts bleeding uncontrollably and they're on unfractionated heparin, we give them a medicine called protamine and it reverses it. That's the benefit of this drug. The other heparin we give is low molecular weight heparin. It is not given IV, it's given sub-Q. Has a longer half-life, so we can just give 1 shot a day or twice a day sometimes. Has a very predictable dose response, so all we need to know is how much someone weighs, and we just give them it. We don't need to check activated factor 10. We can measure it, but we don't because it's so predictable. We can give protamine, but it's not easily reversed. It can have some effect, but it just doesn't. So the difference between these two, this is unfractionated heparin, it's just a longer molecule, and you can see how this molecule binds this antithrombin and basically inactivates it. And this one is just shorter. It's got a lower molecular weight, and it doesn't have any activity on factor 2, thrombin. It only works on activated factor 10. No big deal. So Coumadin. What does Coumadin do? Coumadin doesn't thin our blood. It prevents the recycling of vitamin K. And vitamin K is important for activating these factors, 2, 8, 9, and 10, as well as some other ones. So if you don't have vitamin K, you can't activate those clotting factors. It's got a very slow onset. It takes a few days to get someone up to dose on Coumadin, and that's why they usually get Lovenox while we're waiting for the Coumadin to get up to level. Do you have a question?
Yeah, in von Willebrand's disease, one of the things you do is get vitamin K.
Yeah.
And does that actually affect I saw that von Willebrand's is way high early in the clot.
In the cascade.
Sequence.
Mm-hmm.
Do they give the vitamin K just to make everything else more effective?
No, just to increase that one factor that's deficient. At least that's my understanding.
Okay.
Yeah. But the details of which I'd have to look up, to be honest with you. Yeah. It was called warfarin because it was initially developed at the University of Wisconsin. So WAR is Wisconsin Alumni Research. They funded the research project. So that's why the badgers. Which I will point out, this animal is far higher on the food chain than a gopher. Far higher. They eat gophers for lunch. That might be on the quiz, too. No. So that's where the term warfarin comes from, because it was developed at the University of Wisconsin, which, in case you don't remember, is my alma mater. There are these newer agents, a lot of them. These are scary drugs. They inhibit thrombin. So they act way down at the bottom of that cascade. You cannot reverse them. Well, you can try to reverse them. They are very, very difficult to reverse. There are some very, very expensive thousands of dollars per dose, which we have like 2 doses in the hospital. It is ungodly expensive to reverse this stuff. And even then, we aren't sure how great it does, but there are studies to suggest that it does work. You can dialyze it off, which obviously takes a huge amount of time. But we're seeing people on Pradaxa, Xarelto, we're seeing them. The orthopedists are using them to prevent DVT, and there's good studies to suggest that they're very good at that. It's just scary when these patients bleed. It's our nightmare, actually, because they bleed, and it's not good. This picture basically kind of just shows it all, the whole clotting cascade, how the platelets start to aggregate here. These are these 2B3A receptors that cause them to aggregate. They form a plug, and then fibrin starts to interweave within that platelet plug. This is a platelet right here and shows how aspirin prevents the generation of this thromboxane A2, which stimulates platelet aggregation. There are other drugs. Remember, Plavix acts on ADP. In fact, here I think I have a slide that kind of shows what these drugs do. They're very complicated, actually, but they work great. And these are, aspirin, as you know, is probably one of the most life-saving drugs we have. It honestly has saved more lives in acute MI than thrombolytics. It's really an amazing drug, dirt cheap, and it works great. Patients that are allergic to aspirin typically get this dipyridamole, which works the same way. Or they can get Plavix or Brilinta. So what about thrombolysis? Thrombolytics basically enhance the degradation of clots by activating our own thrombolytic enzymes within our body. So plasminogen is converted to plasmin by tissue plasminogen activator. Right? Plasmin breaks down fibrin. When you break down fibrin, you actually increase D-dimer, that chemical. That's why we measure D-dimers in patients that we're worried about blood clots in. We're just measuring a breakdown product of clots. So if you have a clot somewhere in your body, you will have higher levels of this D-dimer in your blood. So plasminogen is actually incorporated into the clot as they form. It's just not activated. And then so once it gets activated, it's kind of in there and helps dissolve it. So TPA, which is found normally in our bodies as well, has an affinity for that plasminogen that's bound to fibrin. So when you're developing this TPA that you want to administer to people to increase this, you want that TPA to specifically go for this plasminogen that's bound to fibrin. Because if it just activates random plasminogen all over the place, then you're going to be more prone to bleeding somewhere. So we want it to be fairly specific to the clots, and that's why there are all these different types of TPA out there, because some of them have different half-lives, some of them have different affinities for this fibrin-bound plasmin. The drug that we use is actually made by something called recombinant DNA, which is pretty cool. So they basically sequence the drug that humans make on their own, their endogenous TPA. We've sequenced that. So they basically reproduce that gene. They insert it into the genetic structure of a bacterium, and then they grow bacteria. And these bacteria make human TPA, basically. It's really pretty cool. And that's how a lot of very complicated drugs are made. And again, they kind of tailor it so that it's more specific to fibrin-bound plasminogens. This is what we use it for, and this is about all we use it for. Are heart attacks, strokes, PEs, and clotted catheters. Really nothing else. If there's anything else out there, it's purely investigational. But these are life-threatening clot-related problems. MI, stroke, PE, and clotted catheters. Hint, hint. All right? So, what about ischemic stroke? Does it help? This is probably the most controversial thing in medicine in the last 10 years, and it is still controversial, whether we should give thrombolytics to someone having a stroke. Most of us suggest that this medicine has to be given within 6 hours of the onset of symptoms for it to have its maximal benefit. The longer you wait, the less effective it is. That's not to say that at 8 hours they might not put a catheter in and try to squirt some right by the clot that's up there, because that is something they do. But in general, 6 hours is the maximum. The risk is obvious: serious bleed. It goes up with the severity of the stroke. So if you're completely paralyzed on the left, you can't talk, you're totally ignoring one side, the risk of bleed is very high. And that's because the brain is irritated from not having blood flow. And that irritated brain is friable and can bleed. So the worse your stroke is, the more likely you are to have bleeding problems from giving this. But the worse your stroke is, the more likely you're going to have a beneficial outcome. So that's a little bit of a double-edged sword. In general, 3 out of 100 will be worse. 1 severely, and that's shown in this diagram. This is the summary of the use of thrombolytics in strokes, and what it does is right here. This is what we show patients. I bring this into the room. Every patient I give IV thrombolytics for stroke, I bring this into the room. And this is what it says. That many people, 15 or so, will be normal after we give it. The ones in light green here, they will be better. That many that are white have no effect. These 3 will have a bleed, and this one, the bleed will be so severe that they'll die or almost die. So, it's 1 out of 100. But again, I tell them, we give this for very mild strokes sometimes, and it's the mild strokes that rarely bleed and can get some benefit. So, and that's not even teased out in all these studies. That's more anecdotal. We know the risk of bleeding is less, so the risks are less, the benefits are, yeah, you might be able to, swallow better and not aspirate if we give you this drug. So it's a hard thing to decide. We have to tell patients about this kind of stuff. The bottom line is, it is the standard of care. We do it here, so that's what we do. This plot shows MRS is a modified Rankin score. It is a stroke scale for quantitating outcome after a stroke. This is dead. This is almost dead. Obviously, 0 is minimal symptoms. So you can see that some of the ones that are furthest away that did better are these really, really sick patients. So this is where the benefit is actually maybe worth it. But the downsides are death. But if you're down here and we don't give it, many people would argue that this is a horrible, horrible existence down here. This is vegetated state, long-term care, horrible. And that is why some people would say, I don't want it. The last thing I want is to live down here. Living here is better. So, there may be some benefit. The question is this effect real? And that's what people that question the research, we don't know. So it's loaded with controversy. That's the bottom line. Bridge education pieces that we need to cover. It's blood gases and the acid base. This one is actually just, it's blood gases and blood chemistry. So this is the acid base component. So we'll talk about the components of what the test, can you do it arterial versus venous, and then we'll discuss how to interpret them with what I think is a relatively easy way to figure them out, which I think is worth knowing. So the components of a blood gas, the first is pH. It basically measures the acid-base balance of a liquid. Normal is between 7.35 and 7.45. If you're less than 7.4, so 7.4 is neutral, that has to do with logarithms and the number of protons and all that stuff is complicated, but 7.4 is neutral. Anything less is acidotic. Anything more is alkalotic. If an abnormality has been compensated, the pH will be in that normal range, so somewhere between 3.5 and 4.5, if there is compensation, and we'll talk more about that. Partial pressure of carbon dioxide, you may see it written as PCO2 or PaCO2 versus PvCO2. That just signifies where it comes from. The reality is it doesn't matter whether it's coming from a venous sample or an arterial sample. CO2 is valid in either one. Yes, there are some consistent, very subtle differences. It turns out that those subtle differences really don't matter much. So you can use it from either specimen. It basically indicates the production and elimination, the balance of production and elimination of carbon dioxide at a given metabolic rate. It's determined purely by ventilation. PCO2 is dependent on ventilation, basically. The normal is between 35 and 45, so I was just remember 40, which is similar to that 0.4 for pH.
And then the same range, remember the 7.35, well, you can just think about that 3.5 and 4.5. That 3.4 is a typo, it should be 3.5. So less than 35 is hyperventilation, greater than 45 is hypoventilation. You can also get some subtle abnormalities due to compensation. Then there's the bicarb. It indicates the metabolic acid-base balance. So CO2 is ventilatory or respiratory. HCO3 or bicarb is metabolic. Normal is 22 to 26. I don't have a good way to remember that. If it's low, because this is basically a weak base, if it's low, it's acidotic. If it's high, it's alkalotic. And then again, you can get abnormalities of this to compensation. So when you have respiratory acidosis, you'll increase your bicarb in response to that to correct. That's done in your kidneys. There's also PO2 that is always reported. Again, PaO2 or PVO2. PVO2 is worthless unless it's done from a central venous catheter, and that gets a little more complicated. That can be somewhat helpful. But in general, if you do a venous blood gas, PO2 is not used, essentially. PaO2 is rarely used. It tells you how much dissolved oxygen there is, not how much is bound to hemoglobin. So we would rather look at an O2 sat to know how much someone's oxygenating. We still use this. We used to calculate something called an AA gradient. It's a long story, but it can give us some indication of blood flow to the lungs. For all practical purposes, we use O2 sats to give us an indicator of oxygenation, not PaO2. Because again, it's dependent on the inspired concentration of oxygen. Are they on 4 liters? Are they nose breathing or mouth breathing? That changes things. So it's kind of complicated. But there you can see how we can calculate total oxygen. It's a small component of the other stuff that's bound to hemoglobin, which is the vast majority of oxygen in our system. There's also something that can be useful to look at. It's a calculated quantity called the base excess. And it can give us some idea of the degree of metabolic derangement, whether it's acidosis or alkalosis. So normally it should be 0. There shouldn't be any base excess. And it's calculated based on the bicarb and the pH. It uses something called the Henderson-Hasselbalch equation, which describes how a weak acid dissociates, long story. The beauty of it is that it can give you a rough estimate of the volume deficit. So if there's a base excess of -8, that can mean they're 8 liters down. We used to use this when I was a resident in trauma. The early management in the ICU of a trauma patient, we'd follow base excess and know how we were doing with fluid resuscitation. So that's just kind of a gee whiz thing that base excess can be used to tell you how far down their volume is. When might you think about this? You might think about it in a transfer. You're going to Le Sueur for someone and they just had a blood gas and their base excess was -10. You want to think, wow, this person may need some fluids, because it is a good indicator of that. Again, the arterial versus venous. We use venous blood gases pretty frequently in DKA when we really just want to know the bicarb and the pH. Those values are much worse in a patient in shock. And the reason for that is when someone's in shock, they're basically extracting as much as they can get out of the blood in terms of nutrients and that kind of thing. So there's a wider gradient between arterial capillary blood and venous capillary blood. So it's not as valid in patients that are really, really sick. And so occasionally we can follow venous blood gases and occasionally get an arterial blood gas in these patients to kind of correlate a little bit. But for the most part, we can use either one, again, except for that oxygen component. Typically, an arterial blood gas is obtained from the radial artery. So there's 2 arteries that go to our hand. There's a radial artery. It goes around and it makes an arch just like that, comes right back down to the ulnar artery. So if you mess up the radial artery in general, it's not a big deal. In fact, Dave Larson surprised us all. Somebody had a laceration to their ulnar artery. He says, well, I just tied it off. It doesn't matter because the radial artery's intact. I usually talk to someone before I do that, but that's just his experience shining. But yeah, it's a big arch, so it's fed adequately on both sides. Just like every finger has 2 digital arteries, one on each side. If you tie one off, it's not a big deal. We were trained that we're supposed to do something called an Allen test because a few people have very, very small ulnar arteries, and so you're supposed to occlude them both and then release the ulnar artery and make sure that they have normal cap refill. Nobody does it. It's very, very low yield, so usually we do the blood gas. It's not a necessary thing. Other places you can get it are the brachial artery right here and the femoral artery. These samples must be kept on ice because these things metabolize quickly, and oxygen can just, CO2 can kind of off gas if it's not kept on ice. So how do you interpret it? Well, we just kind of went through the steps with that one case. It's actually not terribly complicated. So the first thing you want to do is figure out, is it alkalosis or acidosis, and that's done by the pH. You also need to pay attention to the CO2 in the bicarb. So if PCO2 is high, that represents acidosis from a respiratory component. If the bicarb is low, that also represents acidosis, but it's from a metabolic component. And then the opposite is true with CO2 and bicarb in terms of the respiratory, which is PCO2 less than 35, so that's hyperventilating, and the bicarb greater than 26, which is metabolic alkalosis. So first, so then you need to figure out, is this a respiratory problem or a metabolic problem? So what you do is you figure out, is it acidosis first? Then you say which one is abnormal or going with that, the CO2 or the bicarb. Okay, so if it's an acidosis, then you should have a high CO2 or a low bicarb, right? Because it's either respiratory or metabolic. So you look at those two values and you figure out which one is abnormal. If it's the CO2 that's high, then you have a respiratory acidosis. If it's the bicarb that's low, you have a metabolic acidosis. And then the converse for the alkalosis stuff. Make sense? Finally, you want to see if it's compensated or uncompensated. First, look at the pH. If the pH is normal, it's compensated, and then you're done. If it's uncompensated, it could be partially uncompensated. So if it's uncompensated, the pH will not be normal again, and the component that wasn't matching the condition. So in other words, if this was a respiratory acidosis, which component wasn't matching the pH? It was the bicarb, right? Because it was a respiratory abnormality. It was the CO2 that matched the pH. So then you look at, is the bicarb, the one that doesn't match, normal? If it's normal, then it hasn't compensated yet. If that other one is abnormal, that means the body's making changes to start to compensate. So that's partial compensation. All right? So that blood gas from that case, remember, was a profound respiratory acidosis, 715. PCO2 is 82. And the bicarb was up from normal. 26 is normal. It was 29. So that's the one that doesn't match because it's respiratory. And it's abnormal. So that means the body's starting to fix it. So, what do you think of this one? Normal. That's an easy one. Okay. Is it normal? No. Abnormal. Acidotic or alkali? Acidotic, that's easy. Metabolic or respiratory? Why? CO2 is abnormal. Compensated or uncompensated? Uncompensated. Partially or total? Is there any partial compensation? No, because that bicarb is in the normal range. It's low, but it's in the normal range. Okay. To compensate, which direction will the bicarb go? Up. Right, because you need to be more alkalotic to compensate for this respiratory acidosis. Good. Normal, abnormal. Acidotic or alkalotic? alkalotic, respiratory, metabolic. Which one's abnormal? The CO2. Right, it's respiratory. Compensated? No, because the pH is abnormal, right? Okay. The bicarb's normal, so it's just uncompensated, not partial. Abnormal, alkalotic. Is it respiratory or metabolic? Metabolic. Why? Because the bicarb's abnormal. Compensated? No. Because the pH is abnormal and the PCO2 is normal. One more. Acidotic, respiratory, alkalotic, compensated, partial. Right? There's that bicarb that's up. That's basically the one we talked about. Any questions about blood gases? All right, you're all pros now. What was that? Okay. Now you're all going to be experts at interpreting chemistries. Talk about common chemistry panels. Details of the most common one we order are that basic metabolic profile. Gives us electrolyte indications, renal stuff, and then glucose and calcium. Talk about LFTs, cardiac stuff, and then some miscellaneous other one. So we have a bunch of panels in the hospital. I actually don't like using them. I like to order what I need, not basically what's in, like the trauma panel. Trauma panel used to have a pregnancy test on it, which doesn't apply to males, obviously. So I'm not a big fan of panels, but they are helpful, you know, for like the sepsis panel. It's a whole bunch of some funky tests that are hard to remember. So in those instances, they can be somewhat helpful. I don't use the comprehensive panel. I just order a basic profile, and I order my LFT separate. It's just how I do it. But many people just order the comprehensive all the time. So that's kind of what they are. We'll talk about troponins. I didn't go over coags. We won't. But I'll talk about a BNP. That's a common one we use. And then some other ones as well. So the basic metabolic profile. First thing on the list is sodium. It basically makes up 95% of the osmotically active substances in the extracellular compartment of our body. There's the normal range. It's very important in determining water balance. You can look at the sodium. If the sodium is 150, you know that they are deficient in free water. Not necessarily volume, but free water. So hypernatremia can tell us total body water. And that can be from decreased water intake, diuresis, etc., diabetes insipidus, or you can have hyponatremia. I'll talk about them separately. So hypernatremia is decreased total body water. If you're on diuretics, it can do that because that's what we're trying to do is get rid of water. There's a condition called diabetes insipidus, which is a problem with a chemical in our bodies called antidiuretic hormone. ADH prevents us from diuresing. So if there's ADH around, we don't pee, we don't over urinate basically. Alcohol actually inhibits ADH. So when you drink alcohol, you will get dehydrated. It's half the reason you get hungover, because alcohol inhibits that hormone. So if that hormone's not around, you diurese too much. Symptoms, typically you don't get severe symptoms until the levels are over 160. That's scary high. If it gets up to like 180, it can be deadly. Treatment depends basically on what's causing this. If it's, you can get too much release of that ADH hormone, something called SIADH, or syndrome of inappropriate ADH secretion. Cancers can do that. A lot of things that can do that. Diabetes insipidus is an inherent problem with that hormone. If you have that, we can treat you with medicine, or often what we do with diabetes insipidus is just have them really watch their thirst and how much fluids they take in. In general, though, we replace water. So we can calculate based on a level how many liters of water somebody needs, and we replace the water. Do we just give water IV? Can you give water IV? Can't. Because you have to have this osmotic and oncotic pressure, it's called, and if you give water in the veins, anybody knows what happens with red blood cells? They burst, they lyse, that's right. Because the water basically goes in there and they burst. So you have to have salt or you have to have sugar in the water before you can give it IV. So we use like D5, so 5% dextrose plus maybe quarter normal or half normal saline. So some of that then is water. If somebody's sodium is low, there can be a number of causes for that. Cirrhosis, CHF, something called nephrotic syndrome, which is a kidney problem. We have to figure out, do they have hyper, or are they overloaded because of those problems that cause fluid overload? Is their volume status normal, which is called euvolemic, or are they hypovolemic? If they're hypovolemic, we need to replace that volume, and we just use normal saline. Unless their sodium is real low, then we'll give them hypertonic saline, basically to just replace that sodium. You can see the symptoms. You can just get some general flu-like symptoms for mild hyponatremia. Obviously, the lower it is, the more symptoms can be severe. People can have seizures or even be unconscious because of this. It can lead to something called, it can lead to herniation, basically from edema and water fluid changes in the brain. You can herniate from having hyponatremia, basically. So emergent correction, we use hypertonic saline. We give them these 100 ml boluses, usually one, sometimes maybe two. We can give something called desmopressin, which acts on that ADH, which can help retain sodium. If we give it too fast, they can have something called demyelination syndrome, which is a bad neurologic consequence. So this is a critical illness. It has to be managed very carefully. How you correct the sodium. If you do it too fast, you can really screw things up, long and short of it. Potassium, we've talked about this several times. It's very low concentration in the extracellular component. It's very high concentration in the intracellular component. That is because it is actively pumped into the cell by something called the sodium-potassium ATPase. It's a little enzyme that exchanges sodium in the cell for potassium out. They just switch places, basically. You can see the normal levels there. It's critical for nerve and muscle cell function. And obviously, since the heart is a bunch of muscle cells, it's very critical for cardiac function. The most common cause of having an impairment in potassium is either fluid losses or some kidney problem. It's very tightly managed in the kidneys. Normal, healthy adults can eat a bunch of potassium and it will be of no adverse consequence because your kidneys will take care of it. So the way to kill someone with potassium is to inject it IV, and that's how it's used in euthanasia, actually. But in general, we can tolerate eating a bunch of potassium. We just pee it out. The main cause of over or high potassium is from kidney dysfunction or increased cell breakdown. So if you just had a crush injury, obviously you can get high potassium because you burst a bunch of cells, whether it's a muscle cell or whatever, you release potassium and that can cause high potassium. So that's why you have your crush injury protocol, basically. The most common reason we see it is from renal failure. And patients who are in chronic renal failure actually can live with a very high potassium. Their bodies just kind of get used to it. So it's not uncommon to see renal failure patients with a potassium of 6, and they have absolutely no EKG changes. They just tend to tolerate it more. The EKG changes, you've seen them before, you'll see them again. Tall peak T waves and a short QT interval progresses to a long PR interval and a widening of the QRS, and then you get that sine wave treatment. The mainstay of treatment from your perspective is calcium and bicarb, not together because that forms chalk, and then albuterol actually helps as well. That's what it looks like. This is later, but you see those huge tall peak T waves. QRS is already getting wide. When you start to treat it, this is what it looks like an hour later. That is the classic hyperkalemia EKG right there. If this person is having chest pain, what do you need to think about? Could be acute MI, and those could be hyperacute T waves. Yes, they absolutely could. They do look different if you put them side by side. I'm not going to go over that now. But see how tall and peaked those are, especially in lead V3 there. You're starting to lose that P wave. It's very small. This is severe hyperkalemia, actually, with significant EKG changes. Here's another. This is when it gets worse. A sine wave is that up and down appearance, which this one is getting towards. The next EKG can be asystole or even VFib. This is bad. I've told you countless times, burn this in your brain. If you see this, it's bad, bad, bad. This person's going to die if we don't treat it. I'm not kidding. This is a bad EKG. Just remember that EKG. How do we treat it? Calcium is our first line treatment for symptomatic with EKG changes. It basically stabilizes the cardiac membrane, the cardiac resting potential, so that you don't have the arrhythmia potential. So it lowers the risk of VFib. It doesn't change the quantity of potassium in the serum. That's what all of those other treatments do. If you raise the pH, it causes that sodium-potassium ATPase to push potassium back in the cell. There's also a mechanism of getting glucose in the cell that takes a potassium ion with it. So if you raise the glucose and you raise the insulin, you're going to increase the amount of potassium that is brought into the cell, actively taken up by the cell. Albuterol tends to raise our insulin level when we take a beta-2 agonist like that, and that will also help shift potassium in the cell. Asthmatics that we end up admitting and we get a basic profile just to look at it, they almost always have low potassium from using albuterol. It's just one other little treatment that you guys have in your toolbox that can help. We would also give them glucose and insulin. Don't give them an AMPA D50 necessarily. You need to increase the insulin to really have it help. That's something we would do. Lasix can cause you to lose potassium when you diurese. And there's another medicine called Kexalate, which binds it in the intestine, which just shifting the balance of that potassium in the gut can help lower it. And then magnesium, if patients are on DIG, we don't give them calcium. So being on DIG with high potassium, that's a contraindication to giving calcium. Then we can use magnesium. And as we'll talk about in a bit, magnesium and calcium are very interrelated. Any questions about hyperkalemia? That's an important one. It's probably the most important part of this whole business. Chloride, the long and the short of it is we don't really look at chloride a whole lot. It helps, it's in balance with sodium and potassium actually. You can get low, that's a typo, sorry, hypochloremia with dehydration, watering, diuretics. Get something called a contraction alkalosis that can change your chloride, but we don't use that a whole lot. It's just part of it. BUN, blood urea nitrogen. The level depends on kidney and liver function. Ammonia, which is a product of amino acid metabolism, has nitrogen in it. And then our livers combine ammonia with other elements to form a waste product called urea. All animals make this stuff, but I think it's mammals. Yeah, I think mammals are the ones that secrete it differently in urine versus stool. Bird poop has both feces and urine in it. So, but it's all animals make this stuff. It's a byproduct of amino acid metabolism, which we all do. A high BUN can indicate kidney failure, and it's usually goes with an elevated creatinine. We always look at those two together. But you can also just get an abnormal BUN from being in congestive heart failure. And actually, GI bleed, that's a very important one. When you are basically eating a bunch of blood, so if you have an upper GI bleed and you're absorbing all this blood, your BUN goes up from metabolizing all that blood. So if you eat a bunch of red meat, you can actually increase your BUN. But when I see a patient with a BUN of like 80 and the creatinine is relatively normal, the first thing on my mind is a GI bleed. It might be important for the quiz too. But obviously other things, high protein diet can increase it, burns can increase it, a lot of other things. So we always look at that with this creatinine. And creatinine is a normal chemical that's sitting in our body from muscle breakdown. our muscles are always kind of building and dying. That's normal. And every time those muscle cells break, they release creatinine. So we should have a certain amount of creatinine always in our blood. It's excreted by filtration from the kidneys. And if you have high levels of that creatinine in your blood, it means your kidneys are not filtering properly. So with the BUN, we can tell if renal failure is from something called pre-renal or before the kidneys, and that can happen with dehydration. So then you'll have this classic kind of twice the BUN as creatinine, this 2-to-1 ratio. Actually, it's 20-to-1. Or you can tell if it's a kidney function problem where you'll have almost a normal BUN or a slightly elevated BUN, but a real high creatinine, or post-renal, which means obstruction. Your ureters can be obstructed and things are backing up. So you use those two tests just to kind of help us tell what is causing the renal failure. Bicarb, we already talked about. That can give us an idea of the metabolic acid-base balance. There are different normals reported for different tests. That has to do with sample handling and instruments, blah, blah, blah. Our lab typically reports this for the serum bicarb versus a blood gas bicarb. And it's just a measurement of metabolic pH, basically. Glucose, it's no different than getting an AccuCheck. Theoretically, the machine, the instrument is probably a little more accurate, but it doesn't have anything to do with it. Why do you think we might report glucose when we're reporting these other things? Because it is a common source of error with interpreting electrolytes. So what that means is the electrolytes are measured in a given volume. So you inject like 10 microliters of serum into these machines, and it measures the quantity of those things that are there. It measures how much, the quantity of sodium, and it calculates the concentration based on that normal volume. If, imagine, the glucose were like 1,000, or sky high, that glucose is taking up extra volume in that sample. So that's going to skew the calculation of the concentration, right? So if you have a ton of protein or a ton of glucose, that can make that volume abnormal. So that's why glucose is reported with all these things. Because if it's 1,000 and your sodium is 120, you have to think, oh, that's falsely low, because really the volume of sodium that I'm measuring in is smaller than the actual sample volume. It's a little complicated, but the basic is that glucose takes up a known part of that volume that's used in the calculation and can give you false lows. That's why it's reported. Calcium is also reported. It's a very important electrolyte in terms of bone function, bone building and degrading, parathyroid function, and gastrointestinal disease. It makes up about 2% of our body weight. Most of the calcium in our body is in the form of hydroxyapatite. Does anybody know what that is? That is what bones are. So most of the calcium in our body is bones. Connie, were you able to get that quiz printed?
Yes.
Oh, perfect. Thanks. Hypocalcemia can be from a number of different problems. Parathyroid function, magnesium, low magnesium can lead to low calcium. Those two kind of go hand in hand. High phosphorus, phosphorus goes the opposite of magnesium. Vitamin D deficiencies, pancreatitis, many toxic ingestions can bind calcium and make our total calcium low. Sepsis, chemotherapy, lots of things. The symptoms are muscle twitching and cramps, and even fingertip, hand and wrist cramps, facial cramps, tingling around the mouth or tingling in the fingertips. Why are those symptoms worth mentioning? Tingling in the fingertips. What do we all think of when we think of tingling in the fingertips? Hyperventilation. Hyperventilation is a diagnosis of exclusion. Just because someone has cramps in their fingertips or tingling around their mouth doesn't mean that they're freaking out and just hyperventilating. We see this a fair amount, actually, and there are some cool tests we do, some physical indicators. We can tap on the facial nerve, and it'll cause the facial muscles to twitch on that side. You can put a blood pressure cuff on and inflate it, and they'll get a fairly prompt cramping of their hand. Those are the names for those signs that I can't tell you. So if someone has symptoms of hyperventilation, they have to be truly hyperventilating to have those symptoms. So don't always jump to hyperventilation. This can definitely be an electrolyte problem or a calcium problem. Treatment, we usually use calcium gluconate, but calcium chloride can help as well. We don't treat it in the field. If you see a prolonged QT, because that can be calcium, don't think you're going to give calcium chloride. You can precipitate cardiac arrest by correcting calcium deficiencies. So it's not, you don't have calcium chloride to necessarily treat hypocalcemia. You have it to treat hypofluoric acid and some other things. Hyperkalemia, not this. Obviously, because you can't measure it in the field. That's why. The opposite, again, malignancies, parathyroid hormone problems, renal failure. Renal failure patients commonly have high calcium. The way we remember the symptoms in medical school are from groans, moans, bones, stones, and thrones. It's very painful to have high calcium. You can get kidney stones, abdominal pain, constipation. Those are the common ones. Just general body pain is the most common. Naturally, it will kind of diurese you, so you'll tend to urinate and drink more. Treatment for it depends on the cause. There are some medical therapies we can give. A medicine that can decrease it. It's called pamidronate. Otherwise, it's typically more a parathyroid problem, and then it's surgical. You remove the parathyroid glands. Other basic metabolic things, we used to have this, we called it a Chem 10. They got rid of that because too many people were ordering magnesium and phosphorus levels when they don't need it. The only time magnesium can be an important or a commonly important thing is when it's used as a medicine for OB stuff, and then alcoholics tend to have low magnesium. Typically, or at least we don't even measure it. We just give them magnesium. We just give them 2 grams of magnesium IV, typically in that banana bag that we hang that has thiamine, folate, multivitamins, and magnesium in it. Liver function tests, there are many components to that. The main ones you'll see are AST and ALT. Those are enzymes that are released when there's hepatocellular damage. So if you have an infection like hepatitis, or you have a toxic ingestion that causes hepatitis, you'll release these enzymes called AST and ALT. There's another enzyme important in the liver called alkaline phosphatase, and that is released when there's bile obstruction. So kind of like the BUN and creatinine, we can use these enzymes and the alkaline phosphatase to see if it's a hepatocellular problem or is this a bile obstruction or a bile duct problem like cholangitis. Other components of the test are we measure total protein and albumin. Albumin and protein are in our serum to maintain that oncotic pressure to keep our red blood cells from bursting. So those are very important. And then there's bilirubin. Bilirubin, there should be some in our blood. That's a natural product from blood cell breakdown. So when you break down these blood cells, your hemoglobin gets released. It goes to your your liver, and it does something called conjugating it, and then it's excreted in bile into our stool, and that's really what makes our poop brown, for the most part. So it's excreted in the bile into our stool. The other thing, ammonia can accumulate if your liver is not handling that protein metabolism properly. Remember, it's supposed to make it into urea, which we excrete. If your liver doesn't do that properly, you'll build up levels of ammonia, which can make you encephalopathic or not act right. So that's called hepatic encephalopathy, which we just kind of talked about. Other cardiac tests, troponin I. There are lots of different types of troponin, and it's an enzyme that's important for muscle contraction. It acts with actin and myosin to help with a muscle contraction. Troponin T and troponin I are in the heart. Troponin I is an extremely sensitive test for cardiac cell death. Not stressive cardiac cells, but if troponin is released, it means cardiac cells have died, and that means there could be a heart attack, basically. So that's a very important test. We get it on almost every patient that has chest pain. There are a lot of things that can produce false positives. Renal failure. So patients with mild renal insufficiency don't excrete troponin normally, so it can be elevated a little bit. Normal troponin should not be detected in the blood. We'll tolerate a little bit, so even less than 0.03. If it's higher than that, it makes us think there's something going on with heart cell death or one of those false positive things like kidney function, sepsis. There are a lot of different things that cause it. The other thing we look at in terms of cardiac tests is CPK. It's produced from ATP and phosphocreatine kinase. Long story, has to do with muscle contractions, basically. Really, the one we look for is a specific type of CK called the MB fraction, which has to do with myocardial CPK. That is another enzyme that's released with heart cell death, so indicators of myocardial infarction. Another one we use is a proBNP. It's secreted in our body when our blood volume is increased. So if we're fluid overload, our body secretes BNP, and what that does is dilate our blood vessels. What is our first treatment of congestive heart failure? Nitro. What does nitro do? Dilates our blood vessels. Okay? This does the same thing in response to fluid overload. But we can use it as a test. So if there's too much BNP in the blood, then they're probably in failure. We can also use it as an indicator of heart muscle cell dysfunction. And this is a funny one how to interpret. Patients can walk around with levels in the 3000s and we don't necessarily worry about it. So what they do is they do these big, huge studies. They figure out how much BNP they have and then they put it in these percentiles. So so this NYH is a classification of the degree of heart failure, and they break it up into quartiles, so different classes, and then they see how much BNP is. So the average person with moderate, or let's look at severe heart failure, NYH class 4, the average person has a level of 3,500. The 95th percentile, so more of them have a low percentage of BNP, but to really truly use that criteria as a diagnostic indicator of CHF, you need a very, very high BNP. I know, I just confused the heck out of you. Doesn't matter, the bottom line is the levels, interpreting these levels is very complex. That's the bottom line. Lactate, it accumulates pretty rapidly when we are undergoing anaerobic metabolism. So right when you get up and start running and you aren't even hyperventilating to compensate yet, you're building up a bunch of lactate. It's usually pretty clear. It's cleared pretty quickly. Normal levels are less than 2. We use it as a marker for perfusion. The biggest use now is in sepsis. We want to know if someone is in septic shock. We're looking for levels over 4 that can indicate septic shock. We may someday use this pretty routinely in EMS to identify patients in shock early because it can be done with a finger stick device. Getting hospital lab grade finger stick devices is not simple. There are cheap ones that athletes use or sports medicine people use, but those aren't lab standard ones, unfortunately. So you need a different instrument than those cheap $200 ones, unfortunately. And these samples we draw and they have to keep them on ice. They have to be run pretty quickly. Other things, amylase and lipase we use to determine pancreatitis. We can measure thyroid enzymes. Other LDH, there are tons and tons of different chemistries. To end with this, so I'm going to end it there. Enough said. The big one's the basic metabolic profile and kidney function. But any questions? Yeah.
Sorry, quick one on troponin.
Yeah.
Is there any benefit to getting that earlier, like getting it in pre-hospital setting?
No. The question is there any benefit to getting troponin early? And the reason is because troponin takes 4 to 6 hours. Actually, the high sensitivity troponins, we think 3 hours before it starts to be released. So if we get a troponin at 2.5 hours after the onset of symptoms, it's still probably going to be normal. So that's why we admit patients to rule them out for cardiac disease. It's to repeat that troponin at 6 hours and 12 hours because it's so delayed. So no, the answer is no. Any other questions? All right, that's all I got. Thanks. Oh yeah, quiz?
Luckily, it's easy. So we have to talk about the use of a Morgan lens as part of the new scope of practice for paramedics. So first, it's kind of worth reviewing a little eye anatomy. Obviously, the external features, upper lid, lower lid. This white part is called the sclera, and that's actually the white tissue of the globe. Overlying that is the conjunctiva, which is a clear tissue, and that's what gets inflamed when you get a virus or something in your eye, and it turns real deep red. That's usually that thin outer clear tissue that gets inflamed. You can get something called scleritis, where that white part actually gets really red and inflamed. It's usually more like an autoimmune problem, not necessarily an infection. And it has a real kind of almost bluish purple color to it when it gets inflamed like that. It's not something you see very often. So almost always when an eye is red, it's conjunctivitis. So the colored part is called the iris. Overlying that is the cornea. All right, and then the hole in the iris is the pupil, obviously. That cornea is a bit interesting because it's really the only tissue in our body that does not get its oxygen from blood. The cornea gets most of its oxygen, if not all, from just osmosis, from the air, which is a little bit unique. And that's why we actually stopped patching eyes. Whenever you got a scrape on your eye, we used to put this big occlusive patch on it because it felt a lot better. But it turns out you end up depriving that cornea of oxygen, theoretically, and we think that the rate of infection was higher when we used to do that for corneal abrasions. So now we don't. Unless there's a big flap on it, then sometimes we still do because it is incredibly uncomfortable to have a scrape on your cornea. It is a highly, highly innervated little bit of tissue in our body. As you know, if you've ever got anything in your eye, it'll drive you crazy. And when that thing, if you get the thing out and it leaves a little tiny mark on your cornea, it still drives you crazy. Here's a side view, kind of a cutout of the eye. Here's the lens right here. This area right in here is called the anterior chamber, and it's filled with fluid. And a lot of times direct trauma to the eye will result in an accumulation of blood in that anterior chamber, something called a hyphema. Obviously, then the muscles that move the eye are attached here. This back part is called the retina, with the very central part called the macula. The macula is very sensitive to light and is your central vision, but actually you have more detail in your peripheral vision. It's just something that is an interesting thing about how the retina works. That's probably enough. So the Morgan lens is a very small, soft plastic device that goes over the globe that allows for continuous irrigation. It's used for chemical or thermal burns. It can also be used to help remove foreign bodies. So what we do when someone gets something in their eye, usually it's pretty adherent, and oftentimes it's metal or wood, and it needs to be kind of plucked out or scraped out. Theoretically, you could irrigate it out with one of these lenses. I don't know why, but nobody ever does it. Maybe I shouldn't say nobody. Nobody in our practice. It's not a community standard around here. We usually just pluck them out. It's faster and easier. But for chemical or even a thermal burn, primarily chemical is what we use this. It works great, and it's really the mainstay of treatment. You should not use it if you are suspicious or know that there's penetrating trauma to the globe or a suspected ruptured globe. Does that picture, what do you think of that picture? What do you think's wrong with that eye there? Does anybody have any idea? Nope. This green stuff is fluorescein. That's a stain we put in that adheres to the cornea and fluoresces if there's a defect in the cornea. So we look at it with a black light, basically, and it'll be bright green if there's a defect in that layer. It sticks to the tissue below the outer layer of the cornea. So there's a hyphema here. That's a collection of blood. There's a lot of conjunctival injection, we call it, or hyperemia over there. What do you think of the pupil? Not much. What? it's misshaped. And this is a great picture because it's really pretty subtle. If you see a pupil like that, do not use a Morgan lens because they may have a ruptured globe. If the pupil isn't round, unless they tell you, yes, I've had cataract surgery, people that have had surgery on their eyes will often have an abnormally shaped pupil. But even if they told you they had surgery and you see a hyphema and that conjunctival injection, don't use a Morgan lens. So I'm happy I stumbled on that picture because it's pretty subtle. Usually they'll be very teardrop shaped and they'll point to where the defect in the globe is. It's probably right here in this case just because there's a little defect in what's called the limbus where the conjunctiva meets the cornea. But it could also be down here somewhere. But that irregularly shaped pupil is suspicious for a ruptured globe. And then clearly if there's penetrating, something sticking in the eye, you're not going to use that. That's kind of a no-brainer. But an eye that looks like that, don't use this Morgan lens. You can forego topical anesthetic, but you have it, it works good. It makes it a lot more comfortable. So what you're going to do is you're going to attach this little lens to IV tubing. Here they're showing 2 of them because you can do both eyes at the same time. So you attach it to IV tubing, you spike a bag of normal saline, and then you basically have the patient look down, you pull back their upper lid and you tuck it under the upper lid. Then you have them look up and you tuck it in the lower lid. And then you want to just maybe even tape these tubes to their forehead and just tell them to try to relax. It actually is a lot less painful than you would think. The lens itself is floating on a layer of fluid, so it's not like it's even really touching the globe of the eye. It's really not bad. How long do you irrigate? As long as you guys have them, most likely, unless you're way out in the sticks. But if it's just an irritant, 20 to 30 minutes. Ideally, you're going to try to figure out what this is, and you're just going to irrigate them until you get to the ER, probably. For alkali or acid burn, 2 liters per affected eye, then we wait, and then we measure the pH, and then we keep irrigating until the pH is fairly neutral. Alkali burns can take liters and liters. So acids basically just necrose the skin or the tissue, and they're easily rinsed away. Alkaline, or like sodium hydroxide, which is a drain cleaner, that doesn't. It actually does something called saponification. How you make soap is you put lye and fat together, and they kind of have a chemical reaction. And bases or alkalis do that in your tissue. They basically do this reaction with the fat in your tissue, and because they make that soap, if you've ever had drain cleaner on your fingers, you can feel it. It's like greasy, and it doesn't rinse off. So alkaline burns we wash for a long time until we get that pH normal. But that is what a chemical burn looks like on the eye, that real hazy kind of mottled looking cornea. Alkaline burns are horrible, horrible injuries to the eye. You'd much rather get acid in your eye because it washes out right away than you would an alkaline. So tips: reassure the patient it's comfortable. Again, it floats on a layer of fluid. Sometimes kids can even fall asleep with this in, believe it or not. Usually it's because they get so worked up about the original thing and the whole idea of this, and then when they get it in their eye, they actually kind of relax because it feels better, and they can fall asleep. So it's really not bad. They can close their eyes when it's happening, and it's probably better to. Things can get warm if you have like calcium chloride, which is an ingredient in like cement. When you dilute calcium chloride, it actually gets warm. So if patient's telling you, oh, it feels really warm, it's feeling hot, that's okay. They're not going to get a thermal burn from that degree of warmth because there's a continuous supply of fluid going on it, but that's normal with some chemical dilution. You can always put more anesthetic in if it's really bothering them, and what you do is either clamp or pinch the tube for a little bit, just pull down the lid, put it in the lower lid, just wait a minute or two for the anesthetic to work, and then just resume irrigation. It's pretty simple. This is a video from the company that I shortened a little bit because it was painfully long. You'll see why when you see her.
The Morgan lens is molded to fit the unique curvature of the eye and equipped with directional fins, attached tubing, and an adapter. Consider the alternatives for a moment. Traditional methods of eye treatment are inefficient, ineffective. But the Morgan lens, it's so easy to use. Doctors used to tell you to just patch the eyes and bring the patient in. But what if you could begin flushing the eyes and neutralize ocular pH levels en route to the hospital? All with this little device designed in the field by an ophthalmologist for treating severe infections. As a volunteer physician in Vietnam, Dr. Lauren Morgan ran across numerous
Are they appealing to
ocular
you guys
injuries.
with this or what?
And today, thanks
They
to
know
his
the scope of
in-the-field
practice
invention,
changed.
we find the Morgan lens works in all types of environments. Application is easy. First, if one is available, apply a topical ocular anesthetic. Then peel open the sterile packaging, and with the Morgan lens delivery set, attach an IV bag to begin a minimal flow. You can also attach a syringe for a smaller, more controlled application.
So you want
Have
to
the
have it
patient
flowing
look
before
down
you put it in. Just slow
and insert the
flow.
lens under the upper lid. Then have the patient look up, retract the lower lid, and drop the lens in place. Adjust the flow to the desired rate and absorb the outflow with the Mortan Mediduct or with towels. After insertion, the Morgan lens works on its own. Your hands are free to go to work on other injuries or transport the patient from the accident site to and throughout the critical care area. The revolutionary Morgan lens separates the cornea and bulbar conjunctiva from the palpebral conjunctiva, irrigating both surfaces and preventing symblepharin from forming. The Morgan lens is the only device to provide a positive and multidirectional flow throughout the cul-de-sac. This keeps the cornea, conjunctiva, and normally untreated inner eyelid thoroughly flushed. Foreign bodies, even the kind that can't be seen, are removed effectively and thoroughly. Once inserted, the Morgan lens floats on the very layer of solution it provides, separating itself from the
it actually
tender
is
ocular
important to see
tissues
that
and
conjunctival
vaulting the
cul-de-sac
cornea,
does go
never
way back
touching it.
there. So
As
it
the
is very
lens
effective
floats
at
above the
irrigating
eye,
that.
preventing further damage from eyelid movement, the flushing process soothes the injury and provides instant relief to irritated eyes.
So, yeah, I can't really see it good, but this conjunctiva comes way back to almost where those, yeah, right there, where those muscles attach. It's really deep. So, and there's really no good way. You saw the way they were trying with that IV bag, dripping it on there. It just does not get back in there. So it does work pretty good, and it is not as uncomfortable as people think it would be. Any questions about that? Yes. Huh? I don't care. We'll look into putting them on the trucks. It's part of the bridge in general, but it's not a bad idea to have them on the trucks. So.
You have them in the ER, Kevin?
Yes.
Well, then they're stocked in-house, so that makes it a little easier.
Yep. And you have tetracaine, right? You already carry that, so yeah.
How long does the tetracaine last when you flush? 'Cause I
Yeah.
thought it doesn't last.
Not that long. 10, 15 minutes. Well, exactly. The lens provides relief, believe it or not. Once it's on there, it's, well, have you ever burned your hand, have a bad burn, and it feels better in ice water, right? It's the same concept. Your eye will feel much better with that fluid running on it.
I'm just curious because, once that wears off, I know the burn would feel better, but does your eye, all of a sudden you can
Obviously, you've had one on, and
Yeah, it's not bad. I mean, they numb you up to get it on initially, and then after that, it's more of an annoyance than it is painful.
the biggest thing you could do for comfort they don't mention in this video is have your fluids warmed. If you can have them at least room temperature so they're not cold. Any more questions about that? Okay, I think we covered all the bridge stuff.